my talk is on how we manage CLL in Italy as of today. Number one, we use predictive and prognostic biomarkers. Prognostic biomarkers are important for patient counseling, for example, to decide the frequency of follow-up, because some aggressive disease require a frequent follow-up, indolent disease require an infrequent follow-up. Then we use predictive factor to tailor the treatment to the specific need of each single patient. We use the mutational profile of the immunoglobulin gene to sort out those patients with a more aggressive disease when the immunoglobulin gene is in the unmutated configuration. And of course, we use TP53 disruption to decide which treatment to give to the single patient. So that in previously untreated patients at progression, we still use chemoimmunotherapy in patients with a genetically favorable disease as identified by the absence of the unmutated configuration of the immunoglobulin gene and by the absence of TP53 disruption. The same holds true for fit and unfit patients. Whereas we give preferentially new drugs, be it Ibrutinib or Venetoclax, or in a few patients not eligible to Ibrutinib and Venetoclax, idealizing rituximab, when we have the TP53 disruption, either 17p- bifacial or P53 mutation by sequencing. And also we give these new drugs in the patient with the unmutated immunoglobulin heavy chain gene configuration, because these patients do not respond in a satisfactory manner to chemoimmunotherapy. In the relapsed patient, there is little room as of today to chemoimmunotherapy, and we use in the majority of patients new drugs. And now the issue is which drug to use in the single patient, because we have the possibility to use either Ibrutinib or BTK inhibitors. Ibrutinib in Italy can be used, whereas we cannot use you cannot use Acalabrutinib because it has not been registered yet. So the criteria for choosing BTK inhibitors, Ibrutinib or Venetoclax, depends on the characteristic of the single patient. In the presence of cardiopathies or hypertension, we prefer not to use Ibrutinib because it is associated with quite a high incidence of cardiac adverse events, especially atrial fibrillation. And so we would not use Ibrutinib in patients with cardiomyopathy. We would prefer Venetoclax in these patients. And in patients with reduced renal function, with very low creatinine clearance, Venetoclax may pose a problem with tumor lysis syndrome, so we have to be very cautious when using this drug in this patient, in this unfit patient with clearly reduced renal function. In some patients, we have active protocol, innovative protocol, and we can use Ibrutinib with rituximab in the unfit patient. We have preliminary data showing that in patients with a median age of 73 years, we have a very high response rate, 88% of patients respond, and a very good tolerance of this treatment, with 91% of the patient progression-free at 24 months and 94% of the patient alive at 2 years. Another protocol we are using is the combination of Venetoclax and rituximab in young patients with high-risk CLL. And these two protocols fill a gap in Italy because we are not allowed still to use these two drugs in patients in first line, young patients with first line. So that with these protocols, we can offer the best combination to each single patient.